give me just a minute or two, okay? Welcome back, everyone. It's nice to see you all here. I hope you had a great lunch. Mine was very tasty. And I had a chance for my own student to show me through his poster, which was really a thrill. I was really impressed with the posters and had a chance to see maybe about 15 of them. And thank you all for your participation. We have a nice action-packed afternoon with our second keynote speaker. And I like this, that we've had one outside keynote who's a director of a center, and we have one inside keynote. I'm thrilled actually, before I even go there, because I might forget otherwise, I just want to say this would not have happened without the hard work of several people in our center. Our staff is amazing. We have about 25 staff, but I particularly want to highlight a few people. Stephanie Nava, Renee Godwa, particularly they're very important, Aaron Fox and Ashley Miller. Thank you, you four, for what you've done today to make this happen. It's very easy when I can know that I just show up and things are going to go great. And I'm really grateful for that. Dr. Hampstead, we were delighted when we could recruit him from Mri 7 years ago, maybe 7 years. Yeah. Dr. Hampstead, 2014 it says, he was named the Stanley Barrett Collegiate Professor of Psychiatry last year. Is our clinical core lead and really drives a lot of the science that's occurring in the center. He's an expert in functional imaging and non-pharmacological approaches to enhance age-related memory function. I don't need to read this. I know this about you. Through his appointment in the Ann Arbor VA healthcare system, he is well positioned to ensure that our older veterans have access to cutting-edge research and clinical procedures. Dr. Hampstead, delighted to have you here today.
All right. Okay, how well can people in the back hear me? Good, all right. I'll try and project. I'm also starting my watch to make sure I don't run too far over into Amanda's time. So thank you so much. Really just such a pleasure to be here, both presenting, but also in person, and get to see so many of you that we haven't seen for a couple of years, aside from a flat two-dimensional space. So it's kind of nice to see, three-dimensional people. So I'm going to talk a bit, as the title says, about one of the aspects of our research that the group is doing here at U of M that's closely tied with the Alzheimer's Center. And so as you can see, we're going to focus on neuromodulation. I'm going to give you a little bit of a 35, 40-minute overview of some of the areas that seem to hold promise, as well as some of the ways that we've been using them. I'm going to use some case studies that kind of give you nice examples that I think show proof of principle for some of the big methodologic factors that, as I see it, we really need to tackle. So with that, I have no conflicts of interest. Nobody's paying me multi-million-dollar contracts to do any of this work. If anybody would like to, come see me afterward. Definitely want to acknowledge both the NIA and the VA. The VA has funded me for the last 15, 16 years, NIA for the last at least a dozen years. So a lot of support, a lot of interest in this work. And many of you may be wondering, okay, why neuromodulation? Or expanding our focus a little bit more, why non-pharmacologic? And I think that the answer is fairly clear, that right now, existing medications don't do the job. We know maybe that aducanumab appears to clear some of the disease protein, but from a clinical standpoint, there doesn't seem to be much, if any, improvement. So that's where I think we can have a combination of approaches. And I think that's where things like neuromodulation or the cognitive training, that's another focus of ours, can really be paired with the medications to really improve overall functioning in the patients. So again, many of you, everybody here knows this. I'm not going to read these to you, but the basic idea is that really we want to focus on the brain and what's causing the cognitive and the functional and the emotional deficits in our patients. And, so really we use a combination of techniques, and we have a range of things. Some of you may have seen some of our posters out there, and we can talk a little bit more about that if time allows. So the take-home messages: neuromodulation allows us to have a relatively direct and non-invasive both measurement and chance to manipulate the state of the brain. Applied to those with ADRD, I'll show you some evidence that these techniques may allow us to enhance our characterization and that measures of neuroplasticity, or LTP-like plasticity, appear to be most promising at this stage. May also be a viable treatment option. And so I think that what you'll see is, I'm gonna try and use some of these case studies to highlight how we're thinking, at least at this point, about taking the observational data that we use and that we know can help us really diagnose these patients, and how do we translate that into actionable treatment plans. And I'm going to focus just a little bit at the end on some promising techniques, especially ultrasound-based stimulation, which seems to again be pretty promising here. I do want to just acknowledge these caveats up front. There are a lot of limitations in this line of work, and part of that, for any of you who have been involved in medication trials, know that there's a standard pipeline. By the time the medications get into clinical trials, you basically have a sense of how much, for how long, who is likely to benefit. Those steps typically do not exist for these non-pharm interventions, including neuromodulation. So that's a big focus of our work. How much, how long, how often, for whom? Do we need to apply it in a uniform way, which is currently the status quo, versus an individualized approach, which I'll show you, or maybe a combination of individual network-based. So there's a huge parameter space that we need to know, let alone should we apply this neuromodulation before, during, or after cognitive tasks in order to shape the networks of interest or the brain regions of interest. So there's a lot that we don't know that I'm happy to geek out about later. Safety and tolerability, huge, obviously, concern for all of us. These methods, though, so far have very nominal risks. And even if we talk about theta burst, TMS, the rate of seizures is remarkably low, especially in anyone who isn't at a pre-existing risk. So safety and tolerability really becomes the main issue. And again, I can talk about that, but from a safety profile, these are pretty darn good. And then there's a lot of hardware-based questions. This last point here, we actually are doing at-home neuromodulation, and I can talk a little bit about that. I allude to it in one of the slides coming up, but happy to circle back to that. So when I talk about non-invasive brain stimulation, it's a general term that includes methods that use magnetic fields, electrical currents, ultrasound, or light to modulate brain functioning. And we don't have to lesion the scalp, we don't have to implant anything. There's strengths and limitations of this approach, right? So there are several different types. I'm going to talk about TMS. I'll also allude to talk about transcranial direct current stimulation, which is a type of transcranial electrical stimulation. And here you have the basic waveforms. For TDCS, it's on or off, right? You flip that switch, you're applying a steady state current for X amount of time, and then you're shutting it off. Whereas alternating current is kind of our standard sinusoidal wave, which you can set the amplitude and the frequency. And so this is actually, we're wrapping up a systematic review on this, where it looks like groups are often using gamma frequency in those with cognitive symptoms, but like alpha band in cognitively intact older adults. So I think that there are some really interesting possibilities there. I'm not going to talk too much about random noise. It's kind of like TACS, but kind of on steroids and chaotic, and it's literally random. You set the peak to peak frequency and the amplitude and then the frequency, and the stimulator just sends all sorts of current to the head. And again, not going to talk too much about that. I'll, again, like I mentioned a little bit of ultrasound, but there's also techniques using laser or blue light or different wavelengths of light, and sometimes in combination. So one big take-home message is that these transcranial electrical stimulation techniques technically could include electroconvulsive therapy, but they are not defined by it. Again, you can see the difference in the intensity. So ECT uses 700 to 900 milliamps of electricity with the goal of causing a seizure. That is the last thing that we want to do with TDCS or TACS. And we typically use 1 to 3 milliamps. And I'll show you some examples where we're using more than that, but well within the safety limitations. So for those not familiar with TMS, I'm going to walk through a little bit. I'm going to step out of the light here so that the laser pointer can hit the screen a little bit better. So TMS has this is a figure of 8 coil. And basically there's copper wire that's wound really tight around these posts in here. And you pass an electrical current through there. That electrical current generates a magnetic field that then discharges through the head and creates an energy pulse. And so when applied over the primary motor cortex, say of the left hemisphere, right, we know the motor cortex is hardwired. So left side controls the right side of our body unless there's some atypical growth or what have you. You can actually induce what's called a motor evoked potential. And if you hit it just right and with enough pulse, you can make the hand twitch. You can make a leg twitch. You can have phosphemes, which is kind of wild if you've ever had it done, where you can make people see flashes of light or shapes if you hit the right area within their visual field. And it's very transient, very quick. But everything that I'll talk about with TMS kind of relies on this MEP, right? So how much current do you need to put in to that motor cortex in order to elicit that motor response in the contralateral thumb? Okay, so I'll talk about MEPs, and we'll come back to that in a couple of minutes. But the motor threshold is basically how much current do you have to put in to get that response. Now, there are a lot of different things that we can do, and this comes from a book chapter where our colleague Mike Vessia over in the School of Kinesiology is a TMS guru with the motor cortex, really wonderful person as well. So we put this chapter together that's more clinically oriented. And the idea here is that depending on how we structure these pulses, we can measure different systems. And so you can see that with several of these, there are specific neurotransmitters that have been linked with the performance, the enhancement or the decrement of performance, depending on how you time these pulses. So you'll see a few things. For example, the SAI, it basically you provide a sensory stimulus, say in that right wrist. Roughly 2 to 8 milliseconds later, you hit the motor cortex with a pulse. And what you'll see is that this competing sensory information reduces the motor evoked potential that you get when you zap it with the pulse within that time frame. So you'll see some, me allude to some of those. Some of these other ones, you keep the stimulator right where it is, and you send a sub-threshold, kind of a priming pulse, and then a super threshold pulse, and you can actually see some inhibition or some excitation depending on the time frames that you send that second pulse in. Okay, so these are well-established measures of plasticity, and especially when we talk about theta burst stimulation. So traditionally we've had low frequency and high frequency repetitive TMS. And this is what's been approved for the treatment of depression, obsessive compulsive disorder, and so on. So typically what we would do is have a high frequency stimulation protocol delivered over the dorsolateral prefrontal cortex. What has been found is actually you can get more stronger, more persistent effects by doing what's called theta burst. So you give trains of pulses in the intermittent theta burst that are super fast, and basically you can collapse what used to take 40 minutes of stimulation into about 3 minutes. So if you think from a clinical standpoint, you have stronger effects, you have more persistent effects, and you can get more people through in that same amount of time. So if you do a continuous theta burst where those trains of pulses are continuously spaced, you actually get depression in that network. So you get long-term depression as opposed to long-term potentiation. So I'll talk about the LTP, and I'm talking about the intermittent theta burst, as well as some of these others. So emerging evidence really suggests that these may help us with diagnosis. So for example, this is a great paper, Giacomo Koch's group out of in Italy put this out, and this is, I think, 2018. So they had 60 patients with biologically confirmed DAT or Alzheimer's, but with dementia, and 30 controls. And they did all these different measures that I just alluded to or briefly reviewed. And really what they found was that patients with AD showed reduced motor thresholds, right? So it took less energy to get that motor evoked potential to hit. They showed increased SAI, which is interesting because this is believed to be linked to cholinergic activity, and it can be modulated by acetylcholinesterase inhibitors. And then they found less LTP, so long-term potentiation like plasticity. And when they, but then there were no differences in a couple of these other measures. And when they did the area under the curve analysis, you can see that these measures of neuroplasticity, the long-term potentiation, actually showed an ROC of 0.9. So pretty darn good when they ran it agnostic to diagnostic group. So seems to be pretty promising. LTP was unrelated to age, sex, APOE status, or CSF-based amyloid, but it was related to total tau and p-tau in the CSF. Even more encouraging is that it was, in fact, also the amount of plasticity was positively related to memory test performance. And those who had more plasticity were less likely to convert to show disease progression. So pretty promising. Again, for the sake of time, I'm going to go quickly through this. This is a really wonderful work that came out last year that really summarizes both the existing diagnostic characterization type approaches, as well as the interventions. So they've nicely summarized data to where when I show this, you'll see this chart. Basically look for green, meaning there was no change between patients and controls, an increase or a decrease. And a couple of things to point out. So this motor threshold that I talked about, resting motor threshold, you just have somebody sit passively, you hit the motor cortex and their thumb twitches. So this is reduced in pretty much all of these studies with patients with Alzheimer's relative to controls. The more recent study, actually a lot of studies suggest that SAI, that inhibitory marker of cholinergic integrity, is reduced in those with Alzheimer's, and the LTP. Every study that's used it has found that it's reduced. So we're starting to see some pretty consistent results with TMS-based characterization, but then in the MCI group, really, I think it's probably this LTP marker that seems most promising. But again, you can see that I think this goes back to our earlier keynote talking about the definition of, or the biological definition of AD. You start seeing biomarker supported kicking in here more recently. So, you know, I think that this will be especially important for us to be able to integrate with our data sets. And when they looked at, they also did a nice job where basically these circles, the closer they are out to this 100%, means the number of studies within a diagnostic group, and blue is AD, yellow is FTD, red is DLB. But the further out it is, the greater the proportion of the studies performed found significant differences. And so you can see things like LTP is pretty much spot on, SAI, and some motor threshold, but not necessarily cortical facilitation, meaning that the glutamatergic system seems to be relatively preserved. There are a lot of different treatment studies. I'm not going to go through them. I just thought this was a helpful figure to kind of show everybody loves the prefrontal cortex, right? That's the only part of the brain that apparently matters in the world. So, but there are some interesting works. Again, Koch's group hitting the precuneus and showing some significant improvement in memory test performance. So just as with other types of, well, with any of the transcranial stimulation, one of the key limitations is the depth of penetrance, and TMS is especially susceptible to this because you can only target with that figure of 8 coil something about the size of a quarter. So you got to know what region you want to hit, and it only goes a few centimeters deep. So you're mostly at the neocortical surface. Okay, so this is our new space that we moved into just a few weeks ago, and we have TMS units ready to go. So the hope is that we're going to be able to enroll people from the clinical core who have biomarker confirmation thanks to our friends in the biomarker core. We'll have imaging data thanks to our friends in the imaging core, and we'll be able to get these markers of plasticity with our cohort here. So hopefully in a couple of years, we'll be able to come back and kind of show you if these things panned out. So that's TMS. Now, a lot of the work that we're doing right now has really relied on transcranial direct current stimulation. And TDCS, as I mentioned, is a little bit different. So you can see here that this is the wavelength. Again, it's either on or off, right? It's a constant state. So traditionally, you have two pads, two electrodes. There's an anode that puts the current into the head and a cathode that takes the current out of the head. And so you pass the current between these two electrodes, right? Now, in the last couple of years, MRI-based finite element modeling has emerged that allows us to model the electric field within the head that's passing between these. And actually, before I get there, sorry, the idea here is that under the anode is thought to depolarize the resting neurons. And that makes them more likely to have an action potential. Whereas traditionally, under the cathode, has thought to hyperpolarize, making it less likely to have to elicit an action potential. So we're playing with probability. So you remember in TMS, I said we could make it super threshold and we can make it twitch that muscle. Here, we're reducing we're playing around with the probability of neuronal firing. We're setting the conditions necessary to either make it more likely or less likely to fire. So that's an important difference. Now I mentioned those MRI-based models. So what we can do is take an individual's MRI scan, a structural MRI scan. We can then tell the program where we're going to put the anode and the cathode, how much current we're putting in, and based on that, it'll present these beautiful images to tell us where we're targeting. So you're going to see a lot of these images throughout the rest of this talk. And one thing that you can notice is that there is a boatload of current being delivered to the frontal cortex. So we're pretty much hitting the frontal cortex. So anytime if you see a paper that says we did anodal stimulation over the left dorsolateral prefrontal cortex, no, you probably hit 3/4 of the brain based on, depending on where they put the electrodes. So the thing here is that you can see that peak areas, these red areas, are between the electrodes, these two big pads. So what we tend to favor is this high definition approach. And so you can see that this is kind of the montage that we have where we have in this case, we could call this a center anode, and then we surround it with cathodes. What this does is allows us to have very focal, comparatively more focal stimulation, where then we can better target areas and we avoid any of this off-target delivery of stimulation, or at least theoretically, we can minimize it. Right? And I'll talk about the problem with the cathode in a minute. So most of our knowledge about the effects of anodes versus cathodes and TDCS in general come from the motor cortex. So remember I talked about TMS and the motor evoked potential. Well, the way these studies typically go is that you'll get the basic MEP, the motor evoked potential that we just talked about, and then we'll apply TDCS at some amplitude for some duration using some montage affecting the motor cortex, and then we'll get some more MEPs. And when we do that, a couple of basic findings emerge. That under the anode, we typically find that, gosh, the more you use, the better and the more persistent the effects are. And that typically, again, the anode makes things excitable. So using the same amount of current that you did here, which is a 1, after you apply TDCS, you get a much larger response following if you put the anode over the motor cortex as opposed to the cathode. So again, this is that depolarization versus hyperpolarization that I talked about. So theoretically, the anode is excitatory, cathode is inhibitory. But just like anything in life, it's not that simple. The anode is our friend. We can get consistent effects of the anode. Basically, these are different amplitudes, so 1, 2, 3 milliamps in different times. What you can see is that pretty much we always get an excitatory response. A little bit of noise depending on the parameters, but overall the anode is pretty much always excitatory, right? The cathode, though, at 1 milliamp is inhibitory. At 2 milliamps, it's excitatory. And wait for it, at 3 milliamps, it's back to inhibitory. So it's a mess. So anytime that I see studies that are saying, oh, we did, again, that dorsolateral prefrontal, anodal stimulation of the dorsolateral prefrontal cortex, I kind of laugh to myself because no, you didn't. You may have done excitatory in both places. You may have done inhibitory in one and excitatory in the other. And so those have real ramifications, given that we may not want to deactivate areas of the brain, or we may not want to activate specific areas of the brain. So the bigger problem is that motor evoked potentials are not cognition, right? Cognition is slower. It has practice effects. We can't query it every 100 milliseconds. So then we also have what aspects of cognition? It's not an easy answer because different brain regions, different brain networks underlie these different cognitive or emotional abilities. And so how do we reconcile these different levels of measurement? So the bottom line is we really need to establish dose response information for TDCS. And again, if time allows, I'll talk a little bit about functional targeting and when do we pair, should we pair stimulation with cognitive interventions. So to give you an example of how we've tried to move beyond the motor cortex into cognition, we've really spent a lot of time developing ecologically relevant cognitive tasks. So things that our patients complain about. So getting lost is one of them. Now, I won't go into too much detail, but basically this task is our spatial navigation task. We developed two very distinct cognitive processes. One of them is allocentric. And so so we have allocentric and we have egocentric processing that we all use. With normal aging, there's a natural shift away from allocentric that's more spatially based toward an egocentric that's more landmark and I go right, I go left type of approach. And all of you have used this before. So if you think about this example, say that you're driving home and you have the exact same route that you take every day, and that's an example of egocentric. You can do stuff, and I'm sure there are days that you get home and you're like, oh, wow, I don't really remember driving home because you were thinking about 8 million other things. But let's say that there's an accident or a tree has fallen and you have to suddenly pull up your mental map of the environment and navigate around it. That's an example of allocentric, and that's an example of how these two different networks interact. So we developed this task, and I'm going to focus mostly on this allocentric because it's, again, one of the age and disease-related changes. So we validated this first in a group of healthy young individuals. And in fact, we saw a dorsal visual stream, we saw a ventral visual stream, and hippocampal activation that was greater for allocentric. So the task is engaging the brain regions and networks that we want. Great. So what we did was then enrolled another group of healthy young individuals, and we provided an anode over the parietal cortex and a cathode over the prefrontal cortex. So this area was deactivated. So we thought, okay, we'll try and match the cathode with that. Or the other group had the cathode over the parietal cortex and the anode over the prefrontal cortex. And what we saw was that we actually were able to enhance the bold signal in the parietal cortex in a modularity dependent way. So that's, again, proof of principle, healthy young individuals. So then we stepped it up into healthy controls and patients with MCI. And in this study, we just did a single session of TDCS. And we've targeted the right parietal cortex, given its role in spatial processing. And so we used a high definition approach that you can see here that really we wanted to just hit the right parietal cortex and see if we could modulate functioning and if it had any effect on cognition. So Alex Jordan, who you may have met, who has a great poster out there, who's, fortunately we've sunk our claws into and is doing some really fascinating work of his own, looked at the data and looked at connectivity during the allocentric task. And he looked at the connectivity within these primary motor and somatosensory regions that we know really aren't affected by Alzheimer's disease. And he found no difference as a function of active or sham and no difference between MCI and healthy controls. But in the associative networks that are engaged during this task and that are dysfunctional in those with MCI, he actually showed a restorative effect in the MCI patients. Now, what's interesting is the healthy controls really didn't show any change in connectivity, but we restored functioning in the MCI patients. So single session, pretty cool. Long way from a treatment though, but from a physiologic standpoint, looks like we had an effect in patients who have a weakened system. Fortunately, Scott Peltier helped us get some MRS voxels. And so this is a former postdoc, Hedy Lengu, who wrote this up, where when we placed a spectroscopy voxel in this targeted area. And what we found was a significant effective group, but also a significant main effective stimulation. So we increased the amount of GABA within the targeted region, regardless of group. So what was even more encouraging was that when we looked at a control voxel that when we looked at a control voxel that we placed in the contralateral hemisphere or quadrant of the brain, where you can see really no current was delivered, we saw no effect. So this again suggests, well, gosh, we seem to have modulated at least one neurotransmitter. Great. And it's specific to the area that we targeted. So again, from a basic mechanism, pretty encouraging. So how can we integrate some TMS measures? I think that's an interesting question, where if we look at some of the GABA versus glutamatergic functioning, we can align that with MRS, and one of our colleagues, Thad Folk in psychology, is acquiring GABA. Hopefully we can co-enroll between our studies. So now, one of the things that I do think we need to do is rethink our approach to dosing. So far, all of the data I've shown you have given everybody the exact same amount. Everybody gets 2 milliamps or 1 milliamp or what have you. Everybody gets the same montage, the same approach. And that really is the gold standard in the field. And that infers that really the differences in our head size and shape and the shape of our brains, none of that matters. What matters is how much current we're putting in at that scalp level. But again, that assumes all of our brains look as good as this MNI brain. They don't. So this is what we see. So when we see our patients, this is often what we see. So if I set up a montage, which actually this is a true case that made me feel foolish, to be honest with you, this is where we were putting our center electrode, thinking that we were stimulating the inferior frontal gyrus. Yeah, not so much. So what we did was to ask this question of, well, gosh, do individual differences in morphology of the brain matter? So what we did was take 310 brains from the Alzheimer's Center and from my program. We analyzed them using two different montages, a left frontal and a right parietal. And then we extracted how much current was under that center electrode across all 310 people. And we saw that not only did the site differ, so left frontal tended to have more current, or significantly more current delivered than did right parietal, probably because of the thickness of the parietal bone, especially as we age. But look at the variability. So this 0 mark is our reference person, the person who got the least amount of current delivered to that targeted area. And then we normalized everybody to that person. So that's pretty scary, right? It's basically 4.6 to 7.8 times the amount of current, meaning that our reference person would need over 14 milliamps to get the same amount that this person got with just 2. So any of our physicians in the room would probably be mortified to try and prescribe medications with this much variability. So I think that these models allow us an opportunity to standardize our dosing. So I'm going to go into that and kind of show you some evidence, again, just that the amount of current delivered actually matters. So these are 12 cognitively intact older adults. Each of them had 3 sessions of scanning, so 36 total scan sessions, randomized, counterbalanced, double-blinded. We used a montage that targeted kind of entire parietal lobe, into occipital and temporal, using that same spatial navigation task. Again, I'll show you resting state data and the allocentric connectivity measures. And so what we did was develop individualized montages of all 12 of these people. We then took the same nodes that we used to establish connectivity, and we averaged the amount of electrical current that was delivered within each of these networks. And just focus on the colors. So I present effect sizes, given that this is really kind of a proof of concept study, pretty early stage. It's the only one that I know of that's taken this approach. But focus on the medium and large effect sizes, because that is typically what we would power on. And when we look at the anode, the session where we applied the center anode relative to the sham session, we see some large effect size differences in multiple networks and a couple of medium, and it does not match on to the resting state. So this gets back to some of the work that Michelle Carker is presenting out there with a poster, and that Scott Peltier is really guiding Doug Knoll, suggesting that task versus resting state do not give us the same data. So you can see that the patterns of relationships are very different for task and resting state. So what happens when we compare the cathode with sham? A very different pattern of areas. Really, only the cinguloopercular is showing consistent effects of stimulation. And when we compare anode to cathode, we see some really nice effect size differences, just as we would expect, but not really anything in resting. So that makes me say, well, gosh, task really matters. The context matters. And we're not the only ones showing that. Our colleagues down at UF have shown individual variability using big pads, and that the amount of electricity delivered is actually nicely related to the performance and the beta weights in connectivity in that region, but not in a control region that didn't really get stimulation. And so this brings me to a couple of these case study examples that I think for me are really quite important, because it allows us to take that information, individualize stimulation based on the overall presentation of the patient. So when we started this, we had a couple of patients with posterior cortical atrophy that some of our friends in neurology, I think Sammy Barmata, sent over. And we thought, okay, we don't have any other scan data for these people, but let's target where the tau in the literature is deposited, because we heard about its relationship with cognition earlier. So we developed an individualized brain model that you can see nicely targeted the occipital cortex, trying to match where the tau is deposited in, at least in a population level. We then did 30 sessions of stimulation with this individual, and we had an eye tracker that worked at this point, where you can see an increase in the percent of on-target fixations after stimulation that persisted at a 2-month follow-up, right? And reduced latency. So it looks like the patient was better able to fixate, get the information needed, and shift. From an imaging standpoint, univariate analyses, hotter colors show an increase after stimulation relative to before, whereas cooler colors show a reduction. We see bilateral increase, as well as what I think is probably going to be the parietal eye fields. So look at how well that matches with where we stimulated. Dr. Yordan ran some connectivity analyses of the visual cortex, and we saw these areas were all showing these networks were showing a significant increase in connectivity with the visual network, whereas other areas were kind of ramped down after stimulation. Well, how long does this persist? Well, we called the patient back, like I said, a couple of months later, and these are the baseline data I just showed you. A couple of months later, we see all sorts of kind of noise, but in these areas showing reduction, or these areas that showed change after stimulation, we now see reduction, and likewise, we see a reduction in activation in pretty much these same networks that showed the change post, and now we're returning to more of a baseline pattern of connectivity. So that was the first person we ran. We said, wow, this looks pretty cool. So then we had our second person. This time we had 2-year-old clinical FDG PET, and that really showed right occipital parietal hypometabolism. So we thought, okay, let's just create a montage that mostly focuses on that right occipital, maybe a little bit of parietal cortex. Let's see what happens. Unfortunately, our eye tracker died, and it took us months and months to get it through the system to get a new one, which we now have. But we don't have eye tracking data on this person. But we saw unilateral increase in activation, and we saw a change in network connectivity. Now, you may notice these are the areas that showed reduction in the other patient. So is this just noise in the system? Maybe. Or it could be that this person is far less clinically advanced than that first person. So I think that these are all relevant questions, but I think the important thing is that, again, when we called this person back in, we now see a loss of that increase and a shift back toward baseline patterns. So it looks like the stimulation effects certainly wear off, but it looks like we're getting some consistent physiologic change. So what we're doing now is a pilot study where the team, thanks to our colleagues in neurology, have sent over a good number of PCA cases. And so what we're doing is getting amyloid and tau, as well as FDG. And I'll show you the FDG scans that Bob Kepi and his group are just amazing. And so they've been sending us these. And so you can see the amount of variability between these different cases, right? And these are their MRI structural scans. This patient is, we're still trying to get them in the scanner. But you can see how widely the PET scan, or the FDG, which measures metabolism, is different. And so what we've done is tried to develop montages that target the areas of primary dysfunction for these folks. We're going to then print off individualized headgear for each person and run them through stimulation. So some of these people are going to be in the office with us, some are going to be remote, and then we're going to call everybody back in and repeat the MRI and neuropsych assessment. So, you know, we'll see how this works. My ongoing R01s really focus on how much, how long, and whom, and MCI in patients with early stage dementia of the Alzheimer's type. Again, we're using amyloid and tau PET to help us identify, not just based on clinical phenotype, but how much disease is present and where it's located, and if that matters. And I know I'm probably just about out of time, but I want to just very quickly focus on low intensity focused ultrasound, which is kind of an up and coming technique. It doesn't, not all units look that scary. You can see this one is a lot less freaky looking, but the idea is literally sound waves can penetrate the brain. They have very focal effects, and depending on the nature of the pulse waves, you can have very, very specific and focal effects. So the difference between a couple of these approaches, transcranial focused ultrasound uses a sinusoidal wave, whereas this transcranial pulse stimulation uses a single burst of energy delivered rapidly, and you get, there are pros and cons to each. So you can see the difference in the beams that result from these pulse waves, and once it gets through the scalp and the skull, the brain, the tissue doesn't matter. The energy flows exactly the same once it's through the skull. So, you know, we've modeled some. I was fortunate to be on this with some colleagues who are gurus at modeling, and you can see that the focused ultrasound will have some off-target delivery, whereas this pulse stimulation can be much more focal. So again, pros and cons. And the idea here is that you could theoretically stimulate areas like the hippocampus that we have very clear disease linkages. So with that, I'll return to the take-home messages. Included our website, including one of our awesome colleagues, Annalise, that many of you know, who's doing awesome work, is just really blowing up, as you heard from Hank earlier. And I really want to acknowledge our collaborators as well as the team. And so we've had a few more people join, so we're going to have to get a new picture here pretty quick, but happy to take any questions if I have any time left. Thank you. Questions?
I have one for you. Sounds like this is going to be individualized for everyone. Is that the way you say everyone's ahead of one?
So the way that I've been running it, yes, because I think that there are a couple of different approaches. So we just finished a large VA study where we had over 100 patients with MCI, and you know, at that time these models didn't exist. So what we're doing is a retrospective analysis where we're creating models using their T1 scans, and we're going to be able to map out dose response relationships given that variability that I showed you. So my thought is right now that yes, we should probably be individualizing this. And whether we take the restorative approach that I showed you with those PCA cases, or if we take a compensatory approach and we target relatively preserved areas, is still to be determined.
Really exciting stuff. I just want to ask really quickly, in the PCA cases and the restorative therapy, you showed the reversion back to the original pattern. I'm wondering about the clinical effects, and if they also, if there was a short-term improvement followed by a reversion back.
Yes, so great. For those who may not have heard the question, Dr. Barmata asked if there's basically a clinical reversion, that if maybe there's improvement, are we going to see that taper off? And that's pretty much what we're seeing, just subjectively. And now we're, I think, getting enough materials and enough data in place that we have a protocol that will be able to better measure that. Because these first few were, let's see if we can get any signal at all. And we had another PCA case, but we didn't have any imaging data on. That person was probably the most advanced, and actually their data were part of this because they're the only ones so far out of everybody that we've done this with, because we've done multiple types of dementia. They're the only one that haven't reported it. So what we typically see is 2 to 3 to 4 weeks in, depending on the severity, the patient, family are saying, something is different. Something is better. And a couple of the patients that we've worked with on PPA, I know have told you the same thing, but you're absolutely right. A couple of months later, they come back in like, hey, can we restart? Because we're back to where we were. And it's an interesting perception, because I think that a lot of times people will interpret that as, well, I got worse afterward. But I think because they're used to the new baseline, and then that goes away. And our clinical measures some of them that we have, suggest that there is no clinical worsening. It's just that perception of whatever that change is, whatever we are doing. So if anyone has ideas about how we can measure this kind of squishy, like something is changing, they're better. How do we quantify that? So I think that's a great point.
Do you intend to extend the timeline at all for that testing?
In which way?
The time, if you've got 1 month markers and 2 month markers, you plan to do 3, 4, 6, whatever.
In an ideal world, right? But that assumes that it's an endless resource. And so I think that it's a great question. How long can we extend that follow-up? When can we map out when we need to jump in with booster sessions? And it's a perfect question. I think right now we're working with very limited funds. And so the idea is, hey, let's get some signal, and then we can build that out to where, again, I mentioned doing things at home. We have patients all over the state of Michigan. A bunch of our participants wanted to take units down to Florida or out to California, and we had to be like, no, that's like $20,000. Like, yeah, let's not travel, especially after my experience with Delta. But that's a different story.
Frontal variant AD and frontal dementia with inherited behavior science are very troubling disorders, very difficult for families and patients. Have you had any PTS on behavioral issues that are frontally based?
Yes, awesome question. Any stimulation of frontally based behaviors? Yes, so I had a slide, but I cut it because I knew I'd probably go over. So it was a patient that I think Dr. Marmada sent over, who had a diagnosis of behavioral variant FTD, but it was confounded by then tumor resection, left frontal tumor resection, and a history of bipolar disorder. But to your point, Hank, the main concerns were really the social behaviors and this callousness that was not typical of this person, that emerged years after these other, after the tumor resection, the radiation. So what we decided to do was to take a network-based approach where we looked at meta-analyses of social cognition, okay, the empathy that's so troubling for families to lose. And we set up an individualized montage. And for the first couple of weeks that we did this, the patient was very resistant, was willing to do it, but let us know every step of the way why this was so unenjoyable for her. After about 2, 3, 4 weeks, and I have this nice timeline of both the patient's comments, our staff's comments, and family members who reached out to us. So somewhere around that 4-week mark, the patient, the team started noticing she's happy, she's laughing, she's joking. The daughter came back in to town and said, "This is like my old mom." The patient started saying, "I feel a lot more like myself." Now, how much of this is placebo? I think is a very reasonable question that I try not to drink our own Kool-Aid, right? So with some of our participants, we've actually done a bolus of sham, and we've had the family members say, "What's going on? Every time we do this, they've improved. They're not improving this time. What are you doing different?" Well, just stay the course. And then we flip the simulator on, and within a couple of weeks, okay, finally, we're seeing it. Why did it take so long? Which then creates an awkward feedback situation when I say, hey, I wanted to make sure that we were being rigorous here. And so, we get these subjective reports. And so I think that, so we have done some of that. And I think that's a real opportunity for moving forward. So I know we got to wrap up. So thank you.
By the way, that was not a setup question.
Okay, so it's my pleasure to introduce our next rec mentee speaker, Dr. Amanda Leggett. Again, Amanda has a very interesting background. She has a PhD in human development from Penn State. She's presently a research assistant professor here in the Department of Psychiatry, correct? Yeah, and an affiliate at the Institute for Social Research. And she's going to talk about yet another interesting dimension of dementia, which is the best of times, the worst of times, the costs and gains of family caregiving for a person living with dementia during COVID. Very pertinent. Thank you.
All right.
Good afternoon, everyone. Hopefully everyone can hear me okay through this mic. Excellent. So it is my joy to shake things up a little bit and to be able to give with you the voice of family caregivers for individuals with dementia. So switching from those who have cognitive impairment or a dementia to the family members and friends who are providing care for them, particularly during these past 2 years of the pandemic and all of the challenges and benefits that that has posed for these family members. And so that is why I chose this quote. Anyone recognize the quote maybe? Yeah, Charles Dickens. It's the opening line of A Tale of Two Cities, the best of times, the worst of times. And I think that quote kind of resonated with me for family caregivers because the pandemic, well, and general society at large, the pandemic has posed so many difficulties, and yet there's really been some positives or some gems, I think, that have come out of the past 2 years that I hope can also improve the caregiving landscape. And so that's what I'm hoping to shine some light on today. During this pandemic period, there's been so much spotlight on our healthcare workers, which has been outstanding, on essential workers in the community, like individuals working in grocery stores. But what about family caregivers? I think they've also been essential workers during this time and some of the unsung heroes of the pandemic, helping to provide care and keeping individuals with dementia maybe out of overburdened healthcare systems. So first, I would like to start by acknowledging my funding sources from my K Career Development Award, and then the associated administrative supplement specific to the COVID-19 research that I'll be presenting today. And then also, of course, very grateful for the support from the Alzheimer's Disease Center here. I'm proud to be a part of the Leaders Initiative. And I'd like to acknowledge 3 members of my team who contributed to this presentation today. So first, kind of giving a little bit of the landscape to get us thinking about caregiving in this stressful time of a pandemic. So we know generally, this became evident very early on in the pandemic, that older age, as well as pre-existing medical conditions, pose a number of challenges and increased risk related to COVID-19. So mortality was significantly higher, of course, in this population. So when we think of individuals living with dementia, their age, their dementia, and a variety of coexisting morbidities were really increasing risk for complications with COVID-19, posing, concern and challenges for their family members who were providing care. And then at this time, as we all know, our healthcare systems were really pivoting to put extreme focus on this pandemic and the unknowns of this situation, maybe taking some focus away from other conditions, maybe delaying care, postponing surgeries, postponing appointments. And so all of this is impacting the care individuals with dementia are receiving. And then when we think about caregivers, the pandemic itself in many ways was presenting a barrier to care provision. So family members, and I'll talk more about this, were having to maybe ask themselves the question, do I go and expose potentially my mother to COVID-19, or do I stay home when my mother really needs this care? So these were really challenging questions that family members were facing on a daily basis. So with the policies that were coming up in March, April, May, the early months of the pandemic, caregivers were really asking themselves these questions. Do I abide by these regulations, or do I continue to provide essential care? What about daily activities as our society shut down and all of us felt the implications of this? For individuals with dementia and their caregivers, they lost a lot of outlets that were really fruitful and important to their quality of life. So things like respite programs, going to church. In my research, I was amazed to hear just how important restaurants, going out to eat, was for individuals with dementia and their caregivers. It provided a type of respite. It gave the caregiver a break from meal preparation. It allowed them some socialization with the waiter and the staff at the restaurants. And when all of that shut down and people were insulated in their homes, they lost some enjoyable stimulation there. Also, as I've said, healthcare systems dramatically changed, formal care systems. So, individuals coming into the home to provide care, but also outside of the home services like adult day services. And then new modalities of care. So, switching to phone or telehealth visits, that was new for all of us, but especially for older adults and individuals with dementia who were less familiar with some of this technology. They were now facing, these appointments in a less personal way over a computer screen. So a variety of challenges popping up here. And so early work looking at caregivers, family caregivers during the pandemic did indeed show some increased stress in these groups. So caregivers were reporting greater fatigue, more mental health symptoms, and even more somatic symptoms like stomach aches and headaches. But on the flip side, again, thinking about the positive here, early research also suggested that caregivers were identifying ways that the pandemic was actually providing benefits to the caregiving situation. So even though the technology maybe had an upfront cost of getting used to it and navigating it, it also had a number of benefits for caregivers to be able to engage in services and supports that they might not have otherwise had access to. And relationship building, people were at home, people were spending more time together. And for individuals with dementia who maybe only have a limited amount of time left, the family members were acknowledging that it was a really special and meaningful time for them to spend with their relative or friend. And then life just slowed down for everyone, right? People were baking bread, people were picking up a new musical instrument, all these sorts of things. So, with the slowing pace of life, caregivers had a new sense of control over what their daily routine looked like without as many outside responsibilities. So, they could really dictate what worked best for them and what worked best for the individual with dementia. So, getting into my work here on caregivers for individuals with dementia, the big kind of picture question I want to ask today is how some of these COVID specific challenges and also supports impacted the caregivers during the pandemic in terms of their well being, their stress, and also some health services utilization. And so the work that I'll be drawing from today is from my K Award, this COVID-style dementia caregiving study. And to give you a little bit of an overview, this is a mixed method study of primary family caregivers for an individual living with dementia. And this started back, this K Award started back in 2017, pre-pandemic. And I was really interested in how caregivers were managing and approaching care, both cognitively in the ways that they think about it, and behaviorally in the ways that they enact it. And with that study ongoing, when the pandemic hit, it was a nice opportunity for me to be able to see not just how are caregivers ordinarily managing and handling care and approaching care when this pandemic, this outside or external stressor came in, then how are they adjusting and reacting here? And so in this supplement study, we recruited 100 primary family caregivers for individuals with dementia. It was our goal to maintain as many of our original participants as possible. The original study was in 2018, and then we did a 6-month follow-up. And so we got as many of our participants as we could to stay. And so we kind of lessened some of our eligibility criteria there. As long as the caregiver still had an active role in care, they could participate in the study. And so there were a few individuals with dementia residing in a long-term care facility in the study. But for the new participants that we recruited into the study, the individuals with dementia were community dwelling, not at the terminal stage of disease. So here's an overview of our sample, again, of our 100 participants, on average 63 years old. One of our limitations here, of course, is the representativeness and, of course, then the generalizability of our sample, but it is predominantly female, which we tend to see in family caregiving, predominantly white. Given that we were recruiting largely in the Ann Arbor area, very highly educated group of caregivers. Majority were spousal caregivers, although we had a quarter that were adult children. And then you can see the largest number here had an Alzheimer's, the individuals with dementia had an Alzheimer's disease diagnosis, but we actually had a really good range of different diagnoses of dementia. And on average, these caregivers had been providing care for 6 years. So most of our caregivers had been providing care long before the pandemic, although some of them were relatively new and even got a diagnosis for their relative or friend right when the pandemic was starting. And so in terms of our measures, again, I said we were interested in looking at some COVID-specific challenges and supports. Some of the measures that I will be drawing from today actually came from items that we developed for the National Poll on Healthy Aging. For those of you who are maybe not familiar, the National Poll on Healthy Aging has been going for several years. It is co-sponsored by Michigan Medicine here and also the AARP. And they've been doing, every few months, they've been doing a poll on a national sample of older adults age, or middle-aged to older adults age 50 to 80 years old. And I happen to be part of an interdisciplinary team through the Biosocial Methods Collaborative at the Institute for Social Research that was just about to kick off a study of family caregivers of ICU patients leaving the ICU to study how the family caregiver interaction impacted recovery following an ICU stint. We were literally going to be starting that study in March of 2020. So we were a multidisciplinary team, just kind of perfectly poised to then pivot and think about caregiving for COVID patients. And so out of this team, we developed some items that we put into this national poll on healthy aging to study some caregiving specific stressors and supports. And so you can see them here. And so in the left-hand column, that's the national poll on healthy aging sample. Again, those are adults aged 50 to 80 years old. And they were providing care for an adult, anyone 18 or older with any chronic disease or disability. And then in the right-hand column, this is our dementia caregiving sample, the style study. And so you can see the proportion of caregivers from these two different samples that indicated these different challenges and support. And so I'll just draw out a couple where you can see somewhat of a striking difference. So our national poll sample, in terms of difficulty getting needed in-home and out-of-home services, only 13%, but 1 in 3 of our dementia caregivers had that challenge. You also see the dementia caregivers more likely to say they had difficulty getting needed medical care for their care recipient. And the one that's really striking is a decrease in support from family and friends. So oftentimes caregiving research looks at a primary caregiver, but that's really artificial way of thinking about things because most individuals are enmeshed in larger support networks. And what this is suggesting is that these support networks really decreased for dementia caregivers during the pandemic, and they were more commonly in isolation and care. So we're going to be looking at these different challenges and supports as predictors of the caregiving experience during the pandemic. I also wanted to add in a couple of other items that we didn't have in those national poll items. So we also asked our caregivers whether their ability to participate in things they enjoyed, again, the outlets outside of the home, like church or going to the gym, whether that was impacted during the pandemic. We asked them whether COVID-related financial difficulties made it more difficult for them to provide care. And then also we asked whether the pandemic created stress in their relationship with the individual living with dementia. And so these are the key predictors we're going to be looking at, and then we're accounting for a variety of demographic and care contextual controls. So of course, age, gender, race, employment status, whether or not they lived with the individual, care intensity in terms of hours provided, and then we did account for the stage of dementia using the FAST score. And so in terms of our outcomes, I'm going to be grouping these in terms of mental health outcomes and then health service utilization. So we look at the CESC, which is a depression scale. Specifically, we're going to be looking at the cut point of 16 or greater, which indicates a clinically significant depression based on that score. The Zurich burden interview gets at caregiving stress and burden. So this is everything from feeling strained and overburdened in the role to kind of worry about their performance as a caregiver. And then we have the positive affect scale here. And then just brief measures or indicators of whether the individual living with dementia had any of these urgent forms of health services utilization since March 2020 or since the pandemic began. So we look at 911 calls, emergency room visits, and hospitalizations. And one of my interests here is really the idea that when you take an individual living with dementia and you think about 911 calls and emergency room visits in particular, really the threshold for that urgent service utilization is a concerned caregiver, right? It's usually the caregiver who's facilitating the individual living with dementia to access that type of service. And so, how are some of these pandemic challenges impacting that service utilization? So simple descriptive statistics I'll share, and then also we have some basic linear and logistic regression models. So into our results here. So first, descriptively, I just wanted to give you a sense of these outcome measures and what that looked like in our caregiving sample. So you can see that 1 in 3 of our caregivers actually met the cut point for what would be considered a clinically significant depressive symptoms based on the CESD. That's actually not that far off from what our sample looked like pre-pandemic. So I was kind of surprised. I expected our rates to be a little bit higher, but that's actually a pretty similar number to our pre-pandemic sample. Our Zurich burden interview score reflects moderate to high burden, moderately high positive affect. And then you can see 20 out of 100 caregivers made a call to 911 on behalf of the individual living with dementia. 27 emergency room visits, or 27 different individuals with dementia had an emergency room visit, and 13 had a hospitalization during the pandemic period. And again, these rates are also a little bit less than I would have anticipated. In some work I'm doing with the National Study of Caregiving, we actually found that half of our sample in a given year had an emergency room visit. So we're actually seeing a smaller rate in this sample. Okay, so getting into the good stuff, getting into the results here, I'll start, each slide will be a different outcome. So starting with the CESD, just to kind of give you a sense of my notation here on these slides, the bolded items are going to represent a theme that you're going to see over the course of the presentation. And then the items that are in a lighter gray color are actually marginal. And I sometimes hesitate to put that up here, but given our sample size, some of these were like P.056. And so I decided to also just give you a sense of maybe some potential there for findings in a larger sample. So in terms of odds ratios here, this is a logistic regression predicting the clinically significant depressive symptoms. We saw that difficulty getting needed medical care increased the odds of caregivers reporting depression. And then marginally so, we saw that financial difficulty that impacted care and relationship stress due to COVID increased odds. And then again, marginal, but factors that reduced odds for depression were actually providing less care to reduce the risk of COVID-19, and then actually receiving info from a physician about caring for someone with COVID-19. So it's interesting. Again, with the National Study of Caregiving data, we looked at caregivers who either increased their total hours of care during the pandemic time or decreased relative to those who stayed stable in their care intensity during the pandemic. And we found that generally speaking, it was the caregivers who increased their total intensity of care hours during the pandemic that reported significantly worse outcomes. So we thought that maybe those providing less care might also have some additional stress because of concern of care that maybe wasn't received by them reducing their care, but their overall depression and stress was actually less. It's really the individuals who were increasing their care load who were bearing the greatest burden in terms of mental health. In terms of the Zurich burden interview, we saw associations with this impacted participation in things that caregivers enjoyed. So if they weren't able to continue participation in some of their desired activities, they were more likely to report burden in terms of caregiving. And then again, you see these common themes of that increased relationship stress with the pandemic and also increased difficulty in accessing medical care for their friend or relative. And then in terms of positive affect here, again, you're going to see a common theme, but individuals had more positive affect if they had new individuals or increased support in their network. And this is kind of an interesting one, but again, it's just marginal that we actually saw an association between those reporting financial difficulty and positive affect. So in terms of that increased support, I showed you that 50% of our dementia caregivers were saying they experienced a decrease in support, but we actually asked caregivers both because we felt they weren't necessarily mutually exclusive. Some individuals might have had to pull their care support back, whereas others might have increased. For example, maybe an adult child chose to take a step back to reduce exposure, but maybe a neighbor was able to increase their support more. So we asked both, and you can see how that increased positive affect for individuals. But again, if they had less relationship stress and if they had less difficulty getting needed medical care, they had more positive affect. Okay, turning now to our health services utilization outcomes. So these are logistic models here looking at individuals who did utilize this service. So in terms of calls made to 911, again, that was 20 of the individuals with dementia who had that. What we saw was that difficulty getting not medical care, but these in-home and out-of-home supportive services actually was increased odds of a 911 call. And we see the exact same thing for an emergency room visit, that if they had difficulty accessing these supportive services, they had increased odds of an emergency room visit. And there was a marginal association there for a decrease in support from family and friends. So really these support structures within the community seem to be playing a role in whether or not emergency services were utilized. And then finally, these findings are just marginal, but you see we also had a very small sample size who were hospitalized during the pandemic. But again, you see the same association there with supportive services. And then if they provided less care to reduce risk, that was associated with less risk for hospitalization. So what I wanted to do now was bring in some of that mixed methods data. So what were our participants sharing about some of these common themes of challenges in accessing medical care and also community-based services, so that they can kind of give a voice to you of that experience. So first you hear one of our caregivers talking about the challenge of not being able to attend the medical services with the individual with dementia. So the caregiver says, first, they, meaning the doctor's office, wouldn't let me go back, which is a problem because she won't remember anything they say in terms of care instructions. We always have to explain to people that I need to go back. And then the caregiver is saying it's hard for them to have that conversation in front of the individual with dementia because they don't want them to feel embarrassed or ashamed. So all of these restrictions on care partners attending services really having an impact. And then here you see another caregiver expressing the challenge of appointment times have been much longer wait times, and the caregiver really having to step up and other family members having to step up to advocate to be able to continue to get an appointment. And then switching to services here, you see a caregiver talking about how calling these respite care agencies and waiting months to find somebody, or someone would never come back or would be scheduled to come and would never show up. These sorts of challenges happening over and over again. And then honestly, this quote, I keep coming back to it because I find it relatively heartbreaking, honestly. But this is a caregiver talking about the individual with dementia trying to independently navigate telehealth, and the individual on the other side, on the health services side, trying to facilitate the telehealth appointment for the individual with dementia, just being really short and demeaning towards the individual with dementia, saying, how do you not know how to use a computer? Just being really rude and making the individual with dementia feel very ashamed. But again, as I said at the start of my presentation, there are also some things that came out of this period that caregivers really found as beneficial that I certainly hope will continue to be part of the care landscape. And one of those things was really the ability to participate in support services globally through Zoom and through these telemechanisms. And so here are caregivers talking about how they engaged in an online support group, and they were able to hear people from all over the country sharing their courageous voices and giving advice to caregivers. And then here's a caregiver saying, like, I actually preferred the Zoom because they like to see someone face to face as opposed to over the telephone. And then it reduced some challenges like having to, prepare the mother with individual dementia and to leave the home. And sometimes that can be a hassle for the caregiver. And so being able to stay in their comfortable environment and engage in the service in this way was actually beneficial. So some silver linings here as well. So just briefly, as I wrap up, as I know it's time for the coffee break, some conclusions. So we did see that challenges in accessing services really tended to increase vulnerabilities for caregivers, particularly medical care access and relationship stress seemed to be associated with mental health of the caregivers during the pandemic period. Whereas on the other hand, being able to access in-home and out-of-home support services was related to important health service utilization for individuals living with dementia. And so I just thought I would mention here the RAISE Family Caregivers Act, which became law in 2018. There's an advisory council that actually presented a variety of recommendations to Congress of areas of change they'd like to see made for caregivers. And their second recommendation to Congress was that family caregivers be recognized, engaged, and supported as key partners with providers of healthcare and long-term services and supports. And I think this data really revealed the importance of that to the health of our caregivers, which is so critical because, as I always say to my caregivers, you can't pour from an empty cup. And so if we expect our family members to maintain these care roles over time, we need to be cognizant of their health and well-being as well. So thank you so much. I know we're over time, but I'm happy to take any questions.
Yeah, so Amanda, I think so. Do you have any way of correcting for disease severity?
Yes, the question was, did we have any way of correcting for disease severity? So we did account in our models for the fast staging of dementia. So that was one way we did that. I also ran the model with also looking at activities of daily living and also behavioral and psychological symptoms of dementia. And we saw similar associations regardless of how we accounted for that. Mm-hmm.
Thanks very much for an excellent.
Thank you.
Amanda described how Zoom actually was helpful to caregivers during the COVID, but I know you all hate Zoom. And you have your final 30 minutes really of this meeting before our, reception at the end to meet informally on the fly in person with the person you wanted to talk to, but you haven't done yet. It might be me, it might be a core leader, it might be someone from the other universities. Or it might be that you really want to go see that poster that you never quite got to. So I encourage you in the next half hour, we're going to come back at exactly 3:20 to do one of those things. The point of the ADRC Symposium is to communicate, and that's what you need to do. Thank you.
You didn't get a virus or something.
I know my phone's been really weird lately too. Let's see.
You go to Microsoft and this.
Let's see. Testing. Thanks, Peter.
Like Peter.
Welcome back. I hope you got some good communication in. I love the fact that we're finishing off our day with three scholar talks from three universities. And we'll kick it off with a Michigan State talk in Irving.
Hi, everyone. I hope everyone got their coffee and we are ready to go and finish this strongly. We have as our first speaker of the last session, Drew Bender from Michigan State University. He actually did his PhD at Wayne State in behavioral and cognitive neuroscience, stayed there for a little while after in the Institute of Gerontology, and then head to Germany, to Max Planck Institute, where he did his postdoctoral fellowship in lifespan development. He's currently an assistant professor in epidemiology and biostatistics and neurology and ophthalmology at Michigan State University. And his research interest is how different factors contribute to changes in brain structure and function in normal aging and cognitive impairment. So, Drew.
All right, you should be able to hear me, can you? Great. Thank you, Irving, for the wonderful introduction. I'm going to start my stopwatch, so I try not to go over. Thanks to everybody for sticking around this afternoon. It's a pleasure to be here. As Irving said, I'm Drew Bender. I'm an assistant professor in the College of Human Medicine at MSU. And today I'll be sharing some findings from my work with data from the MADRC and the University of Michigan Memory and Aging Project. And I have no conflicts to disclose. The only disclosure is that it's nice to be talking and wearing something besides sweatpants. So due to the novelty of the approach that I'm discussing and reporting today, I'll begin with some background about the study rationale and the new diffusion MRI methods for quantifying crossing fiber microstructural complexity. So the myelinated axons and supporting glial cells that constitute subcortical white matter are affected by beta amyloid and phosphorylated tau pathologies through multiple mechanisms and pathways. And axonal degradation and myelin damage is associated with impaired neurotransmission and with other accumulation of pathological features, with particular effects on the outer myelin sheath and the intra-axonal neurotubules. And this has motivated a large amount of neuroimaging, especially using diffusion MRI, to quantify changes in white matter pathways. It's also worth noting that oligodendrocytes and other glial cells are also known to be affected by tauopathies. And so there's the question of whether the changes to axonal integrity are coming from multiple sources. And on this slide are images of blunt dissections of white matter fibers in a human brain. And here I just want to illustrate that there are subdivisions of white matter fibers that include late developing intrahemispheric white matter fibers in the association tracts that are earliest affected by AD pathology, as well as somewhat earlier developing commissural fibers that connect the two hemispheres, and very early developing projection fibers that connect subcortical with cortical regions, and which tend to be more spared by AD pathology. And this illustration from diffusion MRI tractography really illustrates the similarity and the ability of diffusion methods to actually visualize and quantify some of these same pathways. But I want you to note, if you look at the association tract and at the tractography image, there's this region I've highlighted in yellow that shows regions that can include fibers of different spatial orientations that are moving in different directions in the brain, or what we call crossing fibers. And diffusion tensor imaging, which is well known to a lot of dementia researchers, is based on the idea that, let's see if that will work. Maybe not. So you should see something moving in there, but Brownian motion, so the random walk of water molecules in the brain is constrained by barriers to diffusion. And so we can characterize that diffusion and use that information to characterize tissue properties. And so in the brain's white matter, the hydrophobic myelin sheath that encircles axons serves as this barrier to diffusion, and therefore water preferentially diffuses along the fiber tracts. And so when we look in somewhere like the ventricles, we can characterize the diffusion as being fairly isotropic, whereas in coherently organized white matter pathways, this diffusion is anisotropic. And so by sampling this molecular water diffusion in a number of different directions, we can do things like estimate a tensor function, take the diagonal from that in order to characterize a spheroid in space that describes diffusion as a single summary statistic. And this provides measures of isotropic or anisotropic diffusion. And the idea is if you, let's see, which is the, so whereas in the ventricles we see isotropic diffusion, in white matter that's highly coherent, we would see these tightly packed fiber bundles with little space between them. But it's worth noting that this isn't always the rule. In fact, when we use the tensor model to describe white matter orientations, it does a pretty nice job overall when there's a single fiber population. But once there's more than one orientation of white matter fibers, the tensor is no longer accurate in describing the orientation of fibers and becomes more challenging to infer any kind of biological information from. And this is evidenced in part by this figure from work by Ben Urison in human brain mapping 10 years ago, in which we've color-coded the brain, the white matter regions, as a function of the number of orientations of white matter fibers, where red includes 1 and green and blue are 2 and 3 different directions of white matter fibers respectively. So as you can infer, the individual or single orientation of fiber in the brain is really the exception as opposed to the rule, and the rule seems to be more be crossing fibers. So how do we use diffusion imaging in order to quantify this? Well, when we apply the tensor model for something like diffusion tractography, there is specific issues that there is a very sparse representation of the white matter fibers that we're actually measuring. So this motivated the development of alternative diffusion models, including constrained spherical deconvolution. And here we fit a basis function, a response function that accounts for the individual underlying populations or underlying orientations of fibers in the brain. And we use this to characterize diffusion in different directions using what's called a fiber orientation distribution, or FOD, as shown here. And so here we can see in regions with single fiber populations, the FOD has just a single peak going in each direction, whereas there's crossing fibers, it goes in two directions. And when we apply this for something like diffusion tractography, it gives a far more robust estimation of white matter fibers in the brain. But there's more information that we can also derive from the fiber orientation distribution. And so it's worth noting that there is a single largest fiber population, which I've denoted as F1 here, as well as secondary and tertiary fiber populations that cross over that, or what I think of as non-primary fiber populations. And so from these, we can use the FOD to estimate other information. So the length and maxima of each of these peaks provides information regarding fiber density, whereas the width of each of these peaks provides information on dispersion, or the fanning or spread of white matter fibers in a diffusion voxel. But the question remains, despite its value for something like tractography, how do we utilize this information for understanding white matter changes associated with aging and disease? And so 17 years ago, Donald Tournier, one of the originators of constrained spherical deconvolution and one of the key architects of the MR-Trix software package, developed this quantification of what we call FOD entropy. And the idea is that entropy quantifies the amount of information in a fiber orientation distribution. So if the FOD includes a single well-defined peak, then entropy is low. And if the FOD has a large number of peaks or very broad peaks, then entropy is higher. And so thus, entropy provides a different way of characterizing coherence in fiber orientations in a given voxel, making it a natural alternative to measures of anisotropy that are commonly used for tensor models, but which are not necessarily valid for measuring crossing fiber populations. This was followed in 2014 by Till Riffert, who extended this method to utilize the additional information from the FODs regarding fiber density to characterize what he calls structural complexity. And here, this characterizes the amount of information that are from non-primary fiber populations relative to the largest primary fiber population in a voxel. And so thus, both entropy and structural complexity are inversely related to something like FA, fractional anisotropy. And so when entropy is high, coherence or uniformity tends to be low, and vice versa. And this notion is demonstrated in recent work in collaboration with the Polk Lab at U of M. And so here, in a comparison of healthy younger and older adults, we see the expected pattern of age-related decrements in FA, shown in red here. However, when we also model the effects of structural complexity, the CX measure, we see a strong negative correlation between complexity and FA, suggesting that, and we've demonstrated that FA is largely explained by differences in crossing fiber complexity, and the notion that it's just representing differences in integrity may be short-sighted. So for the present study, using data from the UMAP cohort and plasma biomarker data that was processed by Nick Kanan's lab in Grand Rapids, I sought to ask the question is, are these novel measures of white matter organization sensitive to Alzheimer's pathology from plasma biomarkers? Do they provide comparable estimates with other existing diffusion MRI parameters like fractional anisotropy or mean diffusivity, as well as measures from the neurite orientation diffusion dispersion imaging, or NODI model that some people may be familiar with? I think Scott Peltier had that as part of his poster. And relate these differences to cognitive performance. And this was all in non-demented older adults from the UMAP cohort. So the study sample included 48 participants from UMAP, including 18 men, 30 women, and these were equally divided by race. and include 19 cognitively unimpaired or intact and 29 participants with mild cognitive impairments. And there were equal proportions of sex and race for both diagnostic groups. This is the schematic of the image processing pipeline that we used. Primarily, we utilize methods in MR-Trix and FSL software toolboxes for pre-processing, including denoising, Gaussian removing of Gibbs ringing artifacts, eddy current correction, and so on. And we used MR-Trix for the remaining processing steps. And so this involved FOD estimation, generation of a sample-specific white matter template, registration of the individual native FODs to the template, and computing different parameters for each participant, as well as estimating then the CX structural complexity and entropy measures, followed by smoothing. And we subjected these to voxel-based analysis using general linear model regression with dependent variables of CX, entropy, as well as FA and MD in separate models. And then for each of these four, we evaluated individual analyses for 6 different plasma biomarkers, including beta amyloid 42, 40, the ratio of 42 to 40, p-tau 181, total tau, and their ratio as well. And the ratio of p-tau 181 to total tau I haven't really seen reported before, but what I observed was that p-tau 181 was significantly associated positively with older age, whereas total tau was not. So this becomes a different way to look at relative effects of the more toxic species of tau here, and we covaried for handedness and total MoCA score. We limited analyses to the white matter and striatum, and so this is an alternative to either whole brain analysis or to using a skeletonized white matter representation. We wanted to include all the white matter regions that include crossing fibers, as well as adjacent, especially striatal regions, because we can model this using the multi-shell, multi-tissue approaches in MR-Trix that are valid in gray matter as well. And so first we found, I'm going to report the results from our analysis of the structural complexity. And we see that elevated p-tau 181 predicts increased structural complexity in a refined region of the mid-posterior cingulum bundle where it meets the corpus callosum and going into the corpus callosum just anterior to the isthmus as well. We sampled from these voxels the mean value and then related that to differences in in p-tau 181. And we see a strong linear relationship with a R-squared of 0.45, including both MoCA and p-tau 181 in predicting that mean structural complexity measure. And even when we account for or control for age, sex, education, race, and total MoCA score, we still see this very strong relationship. So what's going on here? Well, we took a case of someone from the sample with a low p-tau value and someone with a higher p-tau value, and we can zoom in on the fiber orientation distributions and get a sense of the differences in the actual peaks themselves. And one of the things that we see is a larger size of the fiber orientation distributions in the low p-tau relative to here, especially within these cingulum fiber representations. We then related that sampled value to a composite measure of digit span performance, including forward and backward digit span, and controlling for MoCA score. We still see this strong relationship where higher mean complexity predicts lower working memory performance, even independent of total MoCA score. So turning now to our evaluation of the entropy measure, here we only saw a significant effect of p-tau 181 to total tau ratio, and here higher levels of that ratio predicted higher levels of entropy in an adjacent region. So here we see it more in the body of the corpus callosum going into just above the splenium, as well as in the fornix. And it goes into the hippocampal commissure as well. And that again was significant, even controlling for age, sex, and total MoCA score. That the R value was, or the correlation was 0.5 between our sample entropy values and that ratio of p-tau 181 to total tau. When we relate that to behavior, we see that higher level of entropy predicts lower performance on the Hopkins Verbal Learning Test Trial 1 free recall. Again, still controlling for age, sex, education, race, and total MoCA score. So to summarize some of this work, higher p-tau 181 predicted higher structural complexity in the cingulum and corpus callosum, suggesting the reduced density in larger fibers and an increased dispersion in smaller crossing fibers. I didn't show you those results, but we did observe some additional dispersion measures as well. And that the p-tau 181 to total tau ratio positively predicted a greater FOD entropy in the corpus callosum and fornix. There were no significant effects, however, for beta amyloid, total tau, or any of the analyses, including fractional anisotropy or mean diffusivity. So one way that I tend to think about this is the idea that circulating toxic species of tau have an effect on white matter, and it's consistent with prior patterns that have been reported with regard to cortical binding in PET, where we see in the precuneus and posterior cingulum this strong PET binding across the AD spectrum. And prior diffusion tensor imaging findings with voxel-based analysis using CSF markers of total tau to beta amyloid 42 showed some similar effects. I also looked at this ratio and did not see any significant regions in our analysis, suggesting there's maybe some specific sensitivity or differential sensitivity of CSF versus plasma. And it's worth noting that the corpus callosum and fornix are highly uniform tracts. So should we be seeing changes in complexity in something that's so uniform? So this may be that there is a disruption in some of these axons that is changing their orientation in some fashion. And it's also raises the question is there potential for tau seeding from the hippocampus through the fornix as well? And when we compare these with prior findings, we see that in a seminal work from Duaud and colleagues using tract-based spatial statistics, that white matter complexity in MCI and AD are regionally dependent. So often people are familiar with findings showing lower crossing fibers or higher anisotropy in Alzheimer's disease, as shown in this figure here. However, greater crossing fibers or increased complexity in Alzheimer's patients versus MCI have also been reported in similar regions as we are showing here today. But it's also worth noting that that prior work did not show differences between cognitively normal adults and MCI or just within non-demented older adults. And analysis of crossing fiber regions is simply not permissible when using skeletonization. Nevertheless, using a whole brain or whole white matter analysis may greatly enhance type 2 error. So some future directions include working with newly assayed cases from the MADRC biomarker core that they're currently working on, because increasing the sample size will greatly benefit statistical power. Also evaluating other plasma biomarkers. And Melinda Meyering, a graduate student or a doctoral candidate in my lab, is working on structural connectomic analysis with using graph theory networks to evaluate the effects of plasma biomarkers on those. And we're also looking at the effects, modifying effects of ApoE. And critically, evaluating longitudinal changes. How are ongoing changes in white matter affected by differences or changes in plasma biomarker levels is a key and critical direction that we're also looking into. And last, as the tissue shrinks, as white matter atrophies, the extracellular space increases, and modeling these as a dynamic of free water and tissue simultaneously, we think will give us even an enhanced power to observe early changes. So I do want to acknowledge the sources of funding, including the MADRC's pilot award from 2 years ago, and the P30 awards to the MADRC, as well as the R35 to Dr. Hampstead and R21 to Dr. Kanan. without whose investment and work, none of this would be possible, as well as the collaborators on this, the other folks from the Canaan Lab who've been instrumental in producing this work, and my MADRC rec mentors. And I'd also like to thank all of you for your time and attention.
I think we got time for one more.
Yeah, the correlation between the structural complexity and entropy and the phospho-tau was very limited. And you said one reason might be that it's the plasma markers as opposed to CSF. How likely do you think it is simply a number of cases, a small number of cases so far?
I think that's probably more likely. I mean, it's probably more of a power issue with the voxel-based analyses, although when we do the additional sampled measures and evaluate those offline, then we see a much more robust association suggesting it really is just a power issue in the voxel data.
That said, it's a really promising start. I'm happy to see that.
Thank you.
Okay, thank you very much.
Okay, so our next speaker is Dr. Sarah Elzinga. Sarah is a postdoc in the Feldman Laboratory up in this building, actually. Again, an interesting background. Sarah has a PhD in veterinary sciences from the University of Kentucky. And we're now going to have a return to somewhat more mechanistic work. And she's going to tell us about innate inflammation, obesity, and diabetes underlying cognitive impairment. Sarah?
All right, I'm hoping everybody can hear me okay with this mic. All right, great. Thank you for that introduction. I'm excited to share with you a little bit about my work in my postdoc here at UMich, looking at innate inflammatory mechanisms. Just to give you a quick idea of what I'll be talking about today, I'll give you a brief introduction on obesity and metabolic dysfunction and why they're important in the CNS and in cognitive impairment. I don't know if quite everybody in this room is as familiar with that field, and then I'll talk to you a little bit about why we think inflammation plays a really important role in mediating this association, with a particular emphasis on an innate inflammatory pathway that we've become very interested in, the cGAS-STING inflammatory pathway. Then I'll talk to you a little bit about how we're modeling disease, both in vitro and in vivo, and some of the results that we're seeing out of those models. And I'll finally end with a recent study that we just finished up, where we looked at longitudinal assessments of cognition and metabolic parameters in vivo model, talking about too how we might be able to predict some of this future cognitive impairment. And then of course I'll follow it up with some conclusions. So obesity is a huge problem in the United States and around the world. In the US alone, it's estimated that over 40% of the population is obese. And along with this come increasing rates of metabolic dysfunction. And what we mean by that is anything from the metabolic syndrome to prediabetes onto frank type 2 diabetes. And what we see occurring is kind of a quote unquote typical progression where we have obesity leading to dysregulation of glucose and insulin metabolism. And this typically follows with metabolic syndrome, prediabetes, and eventually onto frank type 2 diabetes with a decreasing function of the insulin-producing pancreatic beta cells. Unfortunately, all of these things predispose patients to the development of multiple complications, and this includes complications of the nervous system. It's a little bit better well established that there are many complications of obesity and of metabolic dysfunction in the peripheral nervous system, namely peripheral neuropathy, but it turns out it affects the brain as well. And what we typically see with this is that it predisposes patients to the development of cognitive impairment, and this ranges anywhere from mild cognitive impairment onto more serious forms of dementia, such as Alzheimer's disease. And we typically see things like effects on mental flexibility, mental speed, and executive functions. And of course, this is a problem because, as everyone in this room is likely aware, we don't really have any viable treatment options for these patients. Now, we're really interested in understanding these underlying mechanisms that promote cognitive impairment and obesity and metabolic dysfunction. And one kind of common factor that we think plays a really big role is inflammation and immune system dysregulation. And what we think is occurring is that obesity and diabetes promote inflammation and immune system dysregulation, and this acts in a feed-forward mechanism that promotes neurological damage and eventual cognitive decline. And as I was mentioning, one of the pathways that we think might be involved in this is this innate inflammatory cGAS-STING pathway. And what this pathway does is it recognizes cytosolic double-stranded DNA and it upregulates pro-inflammatory programming, working through its adapter molecule STING and transcription factors IRF3 and NF-kappa beta. It's fairly well established in the periphery in obesity and metabolic dysfunction that this pathway is upregulated in obesogenic conditions. And what's typically seen is there's an increase in the proteins within this pathway, as well as increases in pro-inflammatory programming, such as apoptosis, increases in crown-like structures in adipose, increases in apoptosis, and decreases in cellular proliferation. It's a little bit less well described in the central nervous system, although it's receiving a lot of recent attention. But essentially, it's the same thing as seen when this pathway is triggered, is this pro-inflammatory programming. And really importantly for us is this new emphasis in neurodegenerative diseases, where it's been implicated in multiple disorders, including Huntington's disease, Parkinson's, and Alzheimer's. So how do we go about kind of understanding some of these underlying mechanisms in our models? So first we approach this in vitro, and we do this by modeling obesogenic conditions in CNS cell types. And what we typically do is we incubate these cells with either palmitate or insulin or their combination for 24 hours. And what we see happens in these cells when we do this is that these neurons become insulin resistant. And we see this in that they are unresponsive to acute insulin stimulation. Why is this important? Well, when we do this and we make these neurons insulin resistant, we see that this promotes pathological Alzheimer's disease processing in the form of increasing phosphorylated tau and phosphorylated APP. And perhaps even more interestingly, in these insulin-resistant cells, this also blunts potential therapeutic effects of insulin and IGF-1 treatment, indicating that this might have impacts on treatment in patients. Now, we also took this model to look at kind of these inflammatory mechanisms, and we did this first in a human hippocampal neuronal cell line. And what we see is that under these same obesogenic conditions, that there is a trending increase in the cGAS protein, which is that DNA sensor in neurons, but not really anything significant in any of the other pathway proteins, although it does look like there might be an increase if we had a greater power or some more replicates. I will say it's worth noting in this particular cell line that these cells are a bit resistant to palmitate-induced cell death, so that might be one reason why we're not seeing a large effect. However, when we modeled those same conditions in a human microglial cell line, we do see a pretty strong, robust effect, indicating to us that these microglia are very sensitive to saturated fatty acid conditions and that they're able to upregulate pro-inflammatory condition or responses. Well, that's always all well and good to start out in our in vitro models, but we also wanted to look at this in vivo. And the way that we typically do this is we model obesity, prediabetes, and cognitive impairment in mice by feeding them a 60% high-fat diet. This diet is composed primarily of lard, and it's very high in saturated fatty acids. And what we can see is these mice have impairments in their glucose tolerance test peripherally, but interestingly, when we look at their central nervous systems, we see that they also have insulin resistance in their brains. And this happens as early as 3 days after starting these animals on diet and is persistent throughout. And you can see that modeled here on the right after 24 weeks on diet. But what about cGAS-STING in these mice? We kind of saw something interesting when we dissected out the hippocampus of mice fed high-fat diet for either 3 days or 20 to 25 weeks. We see a disease state-dependent regulation of this pathway. And that early on, there's a upregulation of cGAS and STING, but we see a downregulation after chronic high-fat diet feeding. Now, this suggests to us that there might be an initial kind of pro-inflammatory burst, but that after chronic obesogenic conditions, there might be an immunosenescence or downregulation of immune responses in the hippocampus. Of course, that kind of made us think, well, timing might be really, really important, especially when we're looking at these inflammatory mechanisms.
So in order to maybe tease out some of these effects of timing and obesity and prediabetes, we performed the same modeling, so high-fat diet feeding in mice, and we did this for a total of a year. And throughout this year, we continually assessed these animals metabolically using glucose tolerance tests, and we had corresponding tests of their cognition. So we're able to not only look at how their metabolism is changing, but we're also looking at how they're affected cognitively. Thanks to the MADRC, we were also able to perform spatial transcriptomics on the brains of these animals. Unfortunately, I don't have that data to share with you today because we haven't analyzed it yet, but we will have that data hopefully to share soon. And what we're able to see in our model is, perhaps unsurprisingly, that our high-fat diet guys robustly gained quite a bit of weight, and that persisted throughout our study. And they also had consistent impairments in their glucose tolerance test. The high-fat diet guys are in blue. But when we looked at the cognition, we saw kind of some interesting results. So earlier on, we utilized some more traditional tests of cognition, namely the Morris-Water maze and social recognition. And these tests are measures of spatial location, spatial location for the Morris-Water maze, and social recognition measures sociability in mice. And we didn't really see any stark differences. But when we exposed them to the puzzle box, which is a task more so of executive function, we did see some interesting things. And just because I'm not sure that everybody's maybe seen this before, I'm going to try and play a video. There we go. So how this task works is that mice are in this puzzle box and they have to escape the light area of the box into the dark area. And what we're trying to see with this is, can they remember these single tasks that they're exposed to? And then once they've gone through all the single tasks, can they remember the tasks and combine them to get through this complex task right here? And this is a standard diet mouse, so he does a pretty good job. But what we see with our high-fat diet guys is a clear impairment in their ability to perform this task. And it's a little bit counterintuitive, as these are survival curves. And here, a better survival is associated with a longer latency or a worse response to the puzzle box task. So it took these high-fat diet mice a lot longer to escape our puzzle box than it did the standard diet mice. And this was persistent through all the time points that we measured with these animals. Now, maybe a little bit more interesting was when we tried to understand if maybe we could predict future cognitive performance. And we approached this in a couple of ways. First, we applied a Cox hazard model, and then we also calculated a concordance index, or a C-index. And we tried to predict these cognitive outcomes using our weight data and our GTT data. And what we saw was that indeed we were able to do so using both models. And that's here with the hazard ratios on top. So a lower hazard ratio means there's a better association between the data. And then that's also true for our concordance index, our C-index here, which the opposite is true. So a larger concordance index indicates a better predictive ability of either our weight data or our GTTs on future puzzle box performance. And this predictive ability just increased as time went on. So the further out we got away from these initial weights and GTTs, the better our predictive ability was. Okay, so in conclusion, we can see that modeling obesogenic conditions in vitro promotes insulin resistance, which in turn promotes pathological AD protein processing. And that insulin resistance also has an impact on therapeutic effects of insulin and IGF-1 treatment in neurons. We see CGAS sting upregulation in neurons and in microglia, which is especially evident in the microglia. And then when we transitioned into our in vivo models, we saw many of these same impacts with central nervous system insulin resistance and a CGAS sting disease-dependent regulation in the hippocampus. And then finally, with our long-term cognitive experiments, we see that these mice have clear deficits in executive function and that we might be able to predict some of these future cognitive outcomes with our weight and our GTT data. And with that, I'd like to thank Dr. Eva Feldman and the Feldman Lab, and of course, all the people that contribute to this research, which was quite a lot of work, especially the experimental models. And to our statistical collaborators, Jung-Akur, Kai Go, Lily Zhao, and Ali Turfa, who helped with modeling the puzzle box and doing some of those predictive analyses. Jeff Murphy and the Murphy Lab for all their help with our cognitive experiments, and then my funding sources, the Edith Bushkin Emerging Scholars Program, my K99, and of course the MADRC. I see him. Yeah, that's a great question. There are quite a few. In fact, this pathway is receiving a lot of interest in cancer research as a way to treat cancer. So there are quite a few inhibitors and actually and agonists of this pathway that we could use. We've tried out a couple of them and not really seen anything too interesting just yet, but we have some more experiments that we want to do, especially in co-culture looking at neurons and microglia together. So hopefully we'll have some good data on that soon. In terms of genetic, we haven't done anything in vitro, but we do have some CGAS knockout mice, and we're trying to generate a microglial specific CGAS knockout animal that we can use to better understand this pathway in vivo.
Sarah, I have to ask, so those mice are getting pretty quirky.
Yeah.
Is there any problem that it could do?
I get that question a lot. So surprisingly, no. And we've had mice that this particular cohort, I think our biggest mouse was 70 grams, big mice. But interestingly, they will squeeze themselves through the tubes, literally pull themselves through. So they do manage to make it. Thanks. Yeah, another really good question. So that's part of my K99 is looking at sex differences because female mice, black sex mice don't develop glucose intolerance or obesity at the same rate that males do. They do eventually develop it, but it takes them a lot longer. And we are seeing in some of our preliminary experiments that there might be some interesting cognitive differences between the sexes, but I don't have any great data to show just yet on that. Yeah.
Good afternoon, everybody. Hope everybody's nice and awake. I'm Peter Lichtenberg from Wayne State University at the Institute of Gerontology. What a great day we've had. And to bat cleanup, Dr. Katherine Kero is going to give her presentation. Katie is currently a postdoc at the Institute of Gerontology at Wayne State. She's a registered nurse. She completed her PhD in nursing at the College of Nursing at Wayne State University. So since she's the last one up, please, let's give her a rousing welcome. Come on up, Katie.
All right. Thank you very much for the warm welcome, and thanks for everyone sticking with us through the very end here. My name is Katherine Kero, and I'm going to finish up our presentations today with a little talk about metacognition. So just to break it down very briefly, we're going to be talking about the discrepancies between cognition as it's measured objectively versus subjectively. So to back up just a quick minute, I'd like to tell you a little bit about the Electra Project. This is the study at Wayne State University led by Dr. Vojko Kaučić and Dr. Bruno Giordani here at the MADRC. And this project is where I'm completing my postdoc training. And the purpose of this project is a community-based approach to early identification of transitions to mild cognitive impairment and Alzheimer's disease in African Americans. And the background as to why this study is necessary is that we know that Black Americans are more likely to develop dementia than are white Americans, but less likely to be diagnosed or receive early treatment. And so early diagnosis that's easily accessible within the community is necessary. The purpose of the study is to detect the earliest possible predictors of cognitive decline using the NIH toolbox, the cognition battery, as well as EEG measures, including ERPs or event-related potentials. We work with a population of older Black and African American adults, age 65 and over, who report perceptions of cognitive decline. So they come in with subjective symptom reports, but no diagnosis of dementia or mild cognitive impairment. So here's a couple examples of some of these measures that we're talking about. So all of these folks are co-enrolled in the MADRC project. So they do undergo the entire UDS battery and go to the consensus conference for a diagnosis. In addition to that, they undergo an EEG recording with a 64 electrode EEG setup. That's an electroencephalography. Before, during, and after a visual motion task on a computer. And then an example here of the NIH toolbox, the cognition battery, we have this picture sequence memory test. So all of these little pictures are shown to a participant one at a time, and then put into the yellow box in a random order. And the participant is asked to sort them back out into the order in which they were presented. So unfortunately, we ended up finding that a large number of the participants with no former diagnosis of MCI or dementia were in fact impaired. 40 to 50% of our participants did have assessment findings that were consistent with a diagnosis of mild cognitive impairment. And so because this study is seeking out those who are cognitively normal with only subjective complaints, the team discussed implementing a new screening protocol to try to target our research recruitment efforts at those who are most likely to continue on with us longitudinally. And so the Electra team pivoted to engaging in this new pre-screening instrument called the TICS-M. It's an objective memory and thinking test, and it can be administered by the phone. So it's easily accessible to a large number of participants. And just as this new screening procedure was being rolled out, the COVID-19 restrictions began. So March 2020, the Wayne State University campus closed, the lab closed. We were not seeing any research participants in person. So the Electra staff pivoted very, very rapidly to develop and implement this COVID cognitive protocol. So the COVID cognitive protocol included the TICS cognition screening over the telephone, as well as several other survey questions. And it's really, in retrospect, a great thing that these data were collected now that we're learning more and more about long COVID and some of the neuropathological consequences of COVID-19, as well as subjective symptoms people experience going on. So the methods of this COVID cognitive protocol include recruitment efforts maintained pretty much the same trajectory as before COVID-19. Most of our participants come to us through the Healthier Black Elders Center at Wayne State University. The procedure, all data were collected by telephone screenings. And the study measures included an RVF, research volunteer form, which has basic demographics, basic health history, a cognitive change questionnaire developed by our PI, Dr. Vojko Kaučić, to measure more systematically these subjective cognitive complaints in the context of COVID-19. Also, the TICS-M cognition screening, generalized anxiety measure, perceived stress measure, as well as survey questions about participants' experiences with COVID-19, including their emotional or affective responses to the pandemic, pandemic-related stressors, personal experiences with COVID-19 themselves or with close contacts, as well as their intent to vaccinate. And hopefully some of these topics will look very familiar to you all, as we had some great poster presenters. We had Sophie Hanna telling us about the anxiety, Colt Halter telling us about the affective responses, and Dwana Bass telling us about vaccination efforts. So to dive into the cognitive measures a little bit more detailed, we have our TICS-M as our objective measure of cognition. It's a 22-item instrument, and it measures cognition on several domains. And some examples of questions that are asked include the serial 7s, which is this test: you start at 100, take away 7, keep taking away 7, and so on. Questions about orientation to yourself, your time, your surroundings, your location, as well as current events. And then questions that address learning and delayed recall of a list of items. Contrast that to our subjective measures of cognition, this cognitive change questionnaire. These items they're 9 items, each measured on a 5-point Likert scale. And an example would be, have you needed to reread something to understand it more or less often during the pandemic, or remembering details of multiple tasks is easier or harder than before the pandemic. So now let's talk about how we're defining metacognition for this study. We're defining metacognition as the ability to accurately self-assess and reflect on one's internal mental processes and evaluate cognitive resources and identify changes in cognitive performance. We know from previous literature that sometimes our ability to self-assess our own metacognitive abilities can be influenced by things like disease states or stress or depression. So the purpose of this study was to examine the relationships between metacognition and COVID-19 related stress, anxiety, and depression in a population of older Black adults during COVID-19. We calculated metacognition as the standardized residual variance between our objective and subjective measures of cognition. Clinically, we can interpret metacognition as the following. A zero discrepancy would indicate perfect agreement between objective and subjective measures. A positive discrepancy would indicate that this is someone who is reporting a large burden of cognitive symptoms, but performing still quite well on objective measures of cognition. In contrast, negative discrepancy would indicate poorer cognitive performance with few reported cognitive symptoms. So when we try to contextualize these different directions of metacognitive discrepancies, we can think about them as positive discrepancies are kind of along the same lines as a subjective cognitive decline. So it's a self-reported cognitive decline, and these cognitive symptoms are not necessarily measured as a decline. On the other hand, the negative discrepancy would lead us to a state of something like anosognosia, so no acknowledgement of deficits, and the cognitive declines are observable with assessment. And with these individuals, we might see this for someone who has more advanced dementia, and we would worry about them for safety risks. Whereas those who have subjective cognitive decline might be at risk for further decline in the future. So let me tell you a little bit about our participants. This graph here shows you where the participants who enrolled in our COVID cognitive actually reside. So this is a neighborhood distress index, like you heard quite a bit about this morning. This one comes to us from the University of Wisconsin, Dr. Kind and Buckingham. This area deprivation index can be interpreted as the more intense red colors indicate a more deprived or distressed neighborhood, whereas the more blue colors indicate a less deprived or more affluent neighborhood. So you can see that the vast majority of our participants did reside in highly distressed neighborhoods. We did have 200 individuals, and the average age was about 75 years. Most of them were female. I was really inspired by Dr. Soul's presentation today and also last fall at the GSA, where she let us know about some of the associations between neighborhood distress and cognitive decline. And so we decided to quantify our participants in this way as well. So the results of our research, we found that 31% of our participants were perceiving worse cognitive functioning as a result of the COVID-19 pandemic. We found correlations between our subjective and objective measures of cognition. And we found that COVID-19 related stressors did explain a bit of the variance in perceived cognitive change. We also found that participants reported more cognitive decline if they had a greater level of negative emotions and higher anxiety. So then looking at our discrepancy index, when we regressed TIC-SM scores onto CCQ and looked at that residual variance, we found that the discrepancy index was correlated with anxiety, perceived stress, and mean negative emodiversity. So you can see here, we discussed that a zero discrepancy would be a very accurate reflection of cognitive abilities. Positive would be someone who's perceiving more difficulties than we're measuring, and negative would be someone who's not really perceiving the deficits that we are measuring. And then anxiety here, a larger number indicates a greater burden of anxiety.
So we can say that higher anxiety, stress, and negative affect were related to a greater perceived cognitive difficulty than we would have expected based on the objective measures. So in conclusion, objective and subjective measures were closely related, but not perfectly aligned. And we think that metacognition is an important measure to include anytime we're talking about subjective cognitive decline, because metacognition kind of anchors those subjective complaints to an objectively measured assessment. We also found that anxiety, stress, and negative emotions are related to metacognition in our population. And we all know that COVID-19 has been a major source of stress for many older adults, and it may be impacting physiological health and perceptions of cognition. Clinically, we know that historically disadvantaged populations and distressed neighborhoods with COVID-19 related anxiety are going to be very vulnerable to disparities, and so they require specific attention and interventions. We know that subjective complaints are crucial in assessment of early stage cognitive decline. Some really interesting work by our colleague Annalise Raman-Filipiak here lets us know that these subjective cognitive complaints are very highly predictive, especially when they're corroborated by an informant report. And we know that metacognition and co-occurring anxiety, stress, and negative emotions should be assessed whenever someone is coming to us with subjective cognitive complaints. A big thank you to our research team, starting at the top left. Thank you to Dr. Bruno Giordani, Dr. Anna Doherty, Allison Mole, Colt Halter, Lorraine DeCerbo, Sophie Hanna, Dwana Bass, Dr. John Woodard, and Dr. Vojko Kaučić.
Yeah, so with subjective complaints being important as part of this testing, I imagine that's more for earlier folks that are earlier in the disease process, because there is a point at which I think that insight isn't there anymore.
I agree with you completely. So Taylor was rightly mentioning that we're talking about folks who are very early in the trajectory of the disease process. So in the early stages, we're really listening to what our participants are telling us. They're telling us that they're perceiving cognitive changes that may not have been recognized yet. Whereas later in the disease process, someone just might not be aware of their own deficits as a result of the disease. And that's what we get into, that anosognosia state, where someone's just not aware of their deficit. They're not able to continually update their own self-perception of their thinking and cognition skills.
Time for one more question? Please.
So I'm curious, how does the pandemic play into this in terms of existing feelings of stress around the pandemic playing into self-efficacy around cognition?
That's a really good question. It's really tough to measure with cross-sectional data. Oh, so how did the pandemic play into these feelings of stress and anxiety? And it's a great question. We assume that the pandemic amplified perceptions of stress and anxiety. We have cross-sectional data, so we can really only speculate here. But people were reporting that their stresses were specifically related to COVID-19. And so the questions were asked in such a way that we did try to communicate to folks that we're not looking for your baseline level of daily stress and anxiety. Although considering the neighborhoods from which these participants were recruited, we assume that the daily chronic stress is there. But these questions were specifically phrased to try to talk about COVID-related stressors that they were experiencing. Thank you.
I think Roger Albin has an announcement to make or something to make.
Yeah, just a real quick announcement. So for the next wave of mentees, please meet Stephanie Nava. Stephanie, raise your hand at the table outside for a group photo after the meeting. Thank you.
Wow, we still have a good turnout here. I've been in this building for symposia that have lasted this long, and there's like 4 people left. And commendation to all of you for still being here. Our theme is beyond amyloid. It certainly can't be beyond COVID, because I started off by saying, keep your mask on, COVID's still here. Then I got a text from my daughter saying, I'm positive for COVID today. And our final talk of the day really talked about COVID. And the reality is, I think that's what an Alzheimer's disease research center needs to be able to do, is to adapt to the dynamic changes that occur, look at the additional factors that contribute to cognitive impairment in our society. And so whether it's the neurobiological impact of acute COVID or long COVID, or whether it's the sociocultural impact of COVID on our lives wherever we live, these are things that we need to be investigating as a field. And I'm delighted to see that our center is participating in that. I've really enjoyed the day. I went to many posters, had tremendous presentations from grad students, staff, postdocs, faculty from multiple universities. I told you that we gave MEASY travel awards to all 9 applicants this year. I wish I could give a poster award to every poster presentee this year, but I can't. I know that there were many meritorious poster award presentations, but we only have 3 to give out today. And I will announce them now. And then say a few more things. And I'm going to announce all 3. And if you're here, please come up to the front and maybe we can get a picture. Norman Shield from MSU. Colt Halter from Wayne State University. And I mentioned that we're hoping to expand our reach beyond our 3 universities. And to that end, I'm seeing something wonderful here. Angela Wayne from Central Michigan University. She may have already left. Well, congratulations to all 3. They each get a $100 certificate. I'll keep Angela's for myself. Cole, here you go. Congratulations. And Norman, yeah, here you go. Congratulations. Thank you. We have a reception, more chance to eat and drink and talk and communicate. Next year, 4 years ago, we had a symposium in Detroit at Wayne State. It was an amazing symposium. This center rotates its symposia annually between Michigan, Wayne State, and Michigan State. So our next year up, it's going to be Wayne State's opportunity to really take the lead here, working with all 3 sites. And so be prepared for that, probably roughly the same time of year next year. Very excited about that. I want to thank again all of our staff. I'm not just going to talk about Stephanie and Aaron and Ashley and Renee, but all of our staff who've participated in helping to make this happen. And I want to give a particular shout out to both of our keynote speakers, Dr. Sudha Seshadri. Is she still here? She left, okay, as well as Dr. Ben Hampstead. And thank you all for being here. Enjoy the rest of your day, okay?